Uh, Good evening, friends, again. Because as we need to, some more people are logging, there was some disturbance in between. What I was telling was in these troubled times of coronavirus, COVID, and lot of other problems, still we are maintaining a lot of social distancing, but still we should keep ourselves in contact. The social distance doesn't mean that social isolation. So these electronics, technology, web media will help us in keeping in touch with each other. And in these difficult times too, we should appreciate efforts of Lupin Laboratories for getting us together on this electronic platform. And not too sure. Hopefully, all of you are listening it well, and hopefully you'll see the slides well. The topic which we thought we would discuss this evening is acute decompensated heart failure and revisiting the strategies to avoid readmissions. Basically, as we know, this is also very apt because some of the cases which are cardiovascular manifestations of this COVID could also be precipitating these heart failure patients. These are supposed to be relatively higher risk patients compared to other routine young patients without any cardiovascular abnormality. So one of these precipitating factors could be that, and we'll see much more as with the time goes how what are various causes, what is it. Before we go on to it, bring best wishes from Apollo Group of Hospitals. Many of my colleagues who are a part of this also have joined this webcast, and I'm very thankful to all of them. I'm able to do this because my colleagues there in the hospital are taking care of patients too. And we also, as a group and a hub and spoke model, continue cardiology coverage in multiple hospitals, and some in cities, some in the periphery. This work was recently appreciated in European Heart Journal. I feel why I make it a point to show this is, I think this is the way to go to treat patients and help each other, and that's how we do the best. And it also helps in some of this maintaining these academic programs and doing good academic work, be it in the form of TCTP or any other conferences which you host. This is a big strength of professional colleagues, and the hospitals also will gradually start appreciating this. Coming back to the topic of today's evening again is heart failure. As we all know, before we go on to decompensated heart failure and how to prevent it, just to briefly to recapitulate, what is heart failure? Basically, any person, if he is not able to do his job, we consider him as failure. The heart is not able to pump, or it's also failing to fill itself. So it's a complex clinical syndrome that results from structural or functional impairment, leading to either abnormality or impairment in ventricular filling or ejection of blood. This is more simpler. Or if European Society said it as typically characterized by typical symptoms of breathlessness, swelling, and fatigue, and accompanied by these signs like elevated JVP, pulmonary crackles, peripheral edema. And this is again caused by structural or functional abnormalities of the heart. So the heart will be able to do the same job with increased pressure. So that is what, as we know, is the definition of heart failure. And to recapitulate before we go on to it. Then, if you see, we were all thinking heart failure is only systolic dysfunction, but significant numbers, maybe about more than half of them also have a diastolic dysfunction. It's now being called as heart failure with preserved ejection fraction, where ejection fraction is more than 50%. So this is something like 30-35% less than that, and this is more than 50, somewhere in between, is also called as mid-range ejection fraction or mid-range heart failure. So this has become more and more apt because the therapies are totally different for these two subgroup of patients. If you see here, once cardiac abnormality starts and then decompensation starts happening, with each episode of decompensation or the heart failure, there will be gradually decrease in the total pumping function of the heart, and disease progresses and the mortality patterns increase significantly. That's why it's very important for us to avoid these worsenings of these patients in between. And if you see this, initially, once this acute phase is over, in the initial period, again, the transition phase, what we call, they still have more chance of again getting into admission, then reach a plateau phase and goes on depending upon the type of patient, type of therapy he's taking. It could go on. And finally, the end stage where you go here, then again each patient has more chances of getting into trouble. So if you see the worsening of heart failure symptoms, if the symptoms increase, then mortality increase by 5 times, and then if the gets hospitalized, again it goes up to more than 6 times. So that's why it's very important. And initial phase, the more mortality is about 10%. A 30-day mortality can increase up to 16%, and with 1 year hospitalizations, mortality can go up to 1 year about 30%. So 1/3 of them could die. And then if you see 5-year mortality is 50%. So in other words to say, then heart failure is more deadlier than many cancers. So much is highlighted about breast cancer, Hodgkin's. I'm not saying it should not be given importance, but if you see heart failure, it has more deadlier mortality than any of these cancers. So 50% of them could die by 5 years, and 1/3 could die in 1 year. That's how it's very important to identify and treat these patients of heart failure in a rightful manner. In India, if you see, India again as a population is huge, and about 25% is the incidence of coronary artery disease, and hypertension is also more in our country, and this is already the leading cause of mortality in India. See cardiovascular diseases, no more infections. We always behave like a developed nation in this. If you see the risk factors which are happening, rheumatic heart disease, though it is decreasing, it contributes only in a minority. Basically, coronary artery disease and hypertension are the predominant causes of this, and the diabetes and other comorbidities also contribute significantly. Other specialty of our Indian patients is they are present very younger, and then presentation of heart failure is almost same, and the rehospitalizations again are same in both male and female. And then, as we said, the mortality increases once the patient gets into rehospitalized. So out of every 3 patients readmitted at least once in 1 year, that is probably about 1/3 of them. If you see, why are we so much bothered about readmissions is, once the patient gets readmitted again, his mortality level, if you see, significantly rises up compared to people in which who are very stable. So the mortality rates have significantly goes up. And if you see what are the factors which are causing this, obviously increasing age, history of stroke, and patients who have high serum creatinine, and suboptimal guideline-directed medical therapy. This is important factor. So if patients do not take medication, if we don't give medicines properly, then there's more chance of these patients getting into trouble and getting hospitalized. So if we recapitulate and see, then as we all see, heart failure is an unresolved problem and happens. A significant number of patients, commonest cause for admissions in our hospital is heart failure, and then some of them stay longer, some of them get discharged in a week's time. India, as I said, the rehospitalization rates are about 1/3. If you try to analyze and see why these patients are getting readmitted, what are the various causes for this, predominantly there could be some disease-related factors, like suddenly patient gets into atrial fibrillation, arrhythmias, fast heart rate, and it could worsen, or could sustain acute coronary syndrome, or sometimes blood pressure because of dehydration, various other things, BP could fall, leading to worsening, and that again leads to worsening of renal function, and then that's how electrolyte abnormalities, many of the other causes could worsen and be causing for the heart failure. And sometimes patients, other general causes like anemia, thyrotoxicosis also could worsen in these patients of heart failure. If you see, some system error factors are basically our medication issues. We don't see the patients on a regular follow-up, and we don't give the optimal dosing. Again, the patients could have trouble. Many patient factors, the most important is drug non-adherence. Many of them would feel that once they improve, they would decrease the medicines, especially some of these costlier medicines. They stop and then land in trouble. They don't follow diet and fluid restriction as told, and that's again an important cause for worsening of symptoms and repeat hospitalizations. And many of the times we must have seen patients, once they are admitted in hospital, with the rest itself they improve. So that's how these are the various causes by which the patients get into trouble again and again. So this is again guideline directed medical therapy. If you see the difference in the mortality, if patient is on optimal medicines, he has very less decreased mortality compared to suboptimal drug therapy. One of the most important factor for patients not doing well is not giving proper drugs. So if you see what are the various types of medication, we will go in a moment, but this is the slide which shows the key components where we should start acute heart failure. Once a patient is stabilized, and then pre-discharge, what are the medications to be adjusted, and then the chronic heart failure phase, what is the medicines regularly, how is he taking, all that will be discussed further. If you see this cartoon, which shows that early after admission stage, once the patient is improving, then if a patient is stabilized a little, then he goes down the hill and then gradually maintains reasonable stability. And then if he is not improving, then again he further worsens. If we try to see what are the various causes, how is it improving, initially we start them on diuretic therapy and the standard drugs, and for some time they could improve. Again, if the worsening is noted, you could increase the IV diuretic therapy, probably also add up some IV vasodilator therapy, and check for any other precipitating causes. And if then the patient is not improving further, then this is the time where we need to go to specialized heart failure clinics, where probably would also take the help of dobutamine infusions and other drugs, and also put them on devices and assist devices, or some transiently sometimes could be tided over by doing various other heart failure devices and medication. And that's how that is possible in higher centers of excellence. If you see the therapeutic algorithm for a patient with symptomatic heart failure, which reduce ejection fraction, and many of you could be familiar with this. So basically, patients once with a symptomatic heart failure, treat them with standard drugs like ACE inhibitors, beta blockers, and then probably diuretics, and then the patient is improving, then it is fine. Then you also try to analyze their symptoms and see whether we put them on additional drugs. In between, the patient has evidences of VT, VF, or if ejection fraction is less than 30%, these recommendations wise, ICD therapy is recommended in these patients. Then in these patients who are already on ACE inhibitors or ARBs and other drugs which are mentioned, if they continue to have symptoms, here is where our new therapy of ARNI has come into picture, and this helps in these patients. And if patient has a faster heart rate in spite of using beta blockers, they can put on Ivabrad, and some of these wide QRS patients sometimes could benefit by CRT and other device therapies. So this is basically the heart failure pathways of various drugs which are used. As we mentioned here, at the onset of heart failure, you use ACE inhibitors or ARBs, beta blockers, receptor antagonists, and then probably as a clinical course, if there is history of arrhythmias, they could go and get this ICD treatment. Then once this acute heart failure stabilizes little, then arrhythmias could also precipitate and worsen. And then gradually, once in the decompensated phase, in the long run, they go for supportive treatment, and probably some of these patients could land in heart transplant and other things. If again, this slide shows basically various drugs which are used, and drugs for management of heart failure, and also some of these secondary causes which could precipitate these problems. Like patient has anemia, then you could correct it. Patient has faster heart rate, you could give Ivabrad. Patient we tend to use this less commonly. The vaccination, other things are supposed to be beneficial in the long run, especially for prevention of recurrent hospitalizations. Also is supposed to be helpful. We need to practice this more and more in future. Then the point of discussion today is this ARNI therapy. This, I would say, is a paradigm shift in the management of heart failure. How we came to know about this is when we studied, when the results of paradigm heart failure came, that's how we came to know another new drug which has come, which is more better than ACE inhibitors, ARBs. That is what the results of paradigm heart failure show. But that was done in the stable patients. So, but before that itself, when we are patient and admitted, hospitalized, and before discharge, whether we can start on these new drugs in the transition phase, that was studied with this Pioneer and this transition trials. If you see, this is another important concept. I think many of the lectures we keep highlighting this. All these years we were only targeting angiotensin receptor pathway by preventing ACE inhibitors or receptor blockers. This is one way of prevention of the decreased production of damage producing molecules. Other pathway, which is actually vasodilator natriuretic peptide sustenance pathway is what is again came into new highlight. The sacubitril, this is prevents degradation of natriuretic peptides into inadequate fragments. That means these are good molecules which heart likes them, and then it decreases fibrosis and has a lot of other additional benefits. And that's how, if you prevent the breakage of these helpful molecules, this is the concept of ARNI, then also prevent this production of more damaging molecules. So combinedly, valsartan and sacubitril, I think this is done the job. And now we are further going into further studies, even the cellular level, cyclic GMP, versigwat, now recently ACC 2020, it was presented, also showed some promise. So all these years we are working on only on this pathway. Now we are working on more on this vasodilatory pathway. Sacubitril valsartan is one, and now you got one more versigwat, which is also has come in just presented in ACC 2020. So now this sacubitril valsartan therapy, which was used, showed significant improvement in this patient care of this. Just to briefly recapitulate, I won't go into details of paradigm because our stress is on prevention of rehospitalization, but paradigm heart failure is again significantly large trial, about more than 8,000 patients in 47 countries, where more than 4,000 each were put on enalapril versus the sacubitril valsartan. And this is one of the studies which are prematurely terminated because the benefits were so huge, and the data safety monitoring board said need not continue the trial because the benefits are so huge. What is the benefits which is a combination of sacubitril valsartan produced is it decreased CV deaths, heart failure, hospitalizations, and by additional 20%. And then all-cause mortality significantly decreased an additional 16%. And the cost without much of increase in any of the side effects, with minimal increase in hypotension, but not discontinuing the drugs. Now, if you see the effects, how much it is beneficial, receptor blockers 15%, ACE inhibitors about 18% benefit decrease in mortality if you see it, whereas the neprilysin inhibitors produce additional 20% benefit over ACE inhibitors or receptor blockers. This is again a significant which come out in the paradigm trial. So what immediately European Heart Journal, European Heart Association and American Heart recommended, and though we practice in India too, is that sacubitril valsartan has become straight away class 1 indication, and with it's recommended for replacement therapy for ACE inhibitors or ARPs, especially very helpful to decrease recurrent hospitalizations in patients who are on symptomatic in spite of ACE and ARPs. So that's how this paradigm heart failure study was studied and in stabilized patients. Now let us see, most of the times we see the patients are initially admitted in hospital. Pre-discharge, we were already practicing this pattern with the sacubitril valsartan. Before discharging itself, we were starting at a small dose, and once the patient is stabilized, we were discharging. But then later on, this same process is studied in this pioneer heart failure trial, in which patients initially, diagnosed patients were randomized to enalapril versus sacubitril valsartan, then in a double-blind fashion here, then in an open-label fashion. For 12 weeks, if they see what was happening, they said, if you see the enalapril reduction of NT-proBNP, which is immediately measured at 2 weeks, compared to those which is done with sacubitril valsartan, there is significant reduction of more reduction of NT-proBNP and also troponin levels, and which indirectly decreased again the problems happening, deaths and hospitalizations in follow-up. So this again happened with no significant difference in side effects like hypovolemia, angioedema, hyperkalemia between the two groups. So this trial concluded showing that you could have significantly greater reduction in NT-proBNP when you start these patients in sacubitril valsartan compared to enalapril, with no significant difference in their side effects. Then later on, immediately, it was also being studied and further followed up these pioneer heart failure patient subgroups, and said that even pre-discharge, if it started, it still does the same benefit. Transition is another study which is again started with sacubitril valsartan therapy rather than directly starting on ACE inhibitors and then changing on to. Before that, then this is de novo patients who are directly started on sacubitril valsartan compared to enalapril again had additional benefits compared to those patients who were initially put on enalapril, then changing out to sacubitril valsartan as recommended before. The patient is symptomatic, but this trial showed us that straight away starting them on this molecule of combination sacubitril valsartan could have additional benefits rather than changing only when the patient is not responding to any inhibitors. So thus, this concluded saying that early intervention of sacubitril valsartan may be considered to delay disease progression in patients with de novo heart failure. So this is again found to be superior approach compared to initial testing with the ACE-ARB, then changing on to. So viewpoint, it came in a lot of trials now. It showed that you don't need to wait and start this molecule only once the patient fails to respond or has significant symptoms. The only thing is we need to identify the patient status before discharge, and then if patient has reasonably maintained blood pressures and at least they should be free of IV diuretic therapy, IV inotropes for about 6 hours and stabilized for about 24 hours, then we start this on this molecule. Pressures are low, you start 1/4 of the regular dose. If pressures are reasonable, you start with half dose and gradually step up and try to attain and come to therapeutic doses in 4 weeks to 12 weeks time. So that's how it is shown to initially in stabilized patients, then in pre-discharge patients. Now we also have data now to show that we need not wait till patients do not respond to ACE inhibitors. Straight away they can be started on sacubitril valsartan combination to have this benefit. If you try to see what are the comorbidities associated in these heart failure patients, apart from the regular therapies of ACE inhibitors, now actually sacubitril valsartan, beta blockers, pneumococcorticoids, diuretics, if any of the patient has antecedent other causes like uncontrolled anemia, chronic kidney disease, and diabetes, these were seen in many of these patients in the large follow-up thing, and it has to be properly addressed and then treated accordingly. And otherwise, you still could feel that patients are not responding properly. Another thing which bothers us is a slight increase in creatinine, which happens when you put them on these molecules. If a patient is having a less than 30% rise, still it is okay. We can try to continue the same molecules, especially if a patient has reduced ejection fraction, don't decrease it. And then if patient has a 30 increase in creatinine values or GFRs more worsens, 30 to 50% rise, then probably in diastolic dysfunction, you stop the inhibitors, whereas in systolic dysfunction, still we try to continue with temporary withdrawal and restarting this molecule again in small doses. But if a patient has a creatinine worsened by more than 50%, probably both you need to stop it immediately. And then if patient has a severe renal dysfunction with eGFRs of less than 20, probably in both the subgroups we need not give. In other words, to say, patients of any creatinine value, you challenge them with a small dose of this, and if increase in creatinine is not more than 30%, still they could tolerate and it could continue in systolic dysfunction. But if it worsens more than 50%, that's where we need to stop these drugs and look for alternative therapies like vasodilators with nitrates and others. So the people who are also concerned whether ARNI is equally safe as ACE inhibitors. That's how this ARNI renal safety was particularly studied, and it is shown that ARNI therapy is much more safer to kidney with less worsening of creatinine. And if you see what are the other causes to which the patients going to worsen hyperkalemia, obviously here I mentioned diabetic patients, COPD, peripheral artery disease, CKD, and patients are additional aldosterone therapy. Patient is also on a potassium sparing diuretic along with it, then probably they tend to go into more of hyperkalemia. So we need to keep that in mind and try to adjust the therapy accordingly. If patient develops hyperkalemia, probably if it is systolic dysfunction, if it is a mild increase in potassium, we try to control other things and still without stopping this. But if it levels cross about more than 6, then probably we will withdraw it. And as of now, there is no definite therapy which has come in available, but the two molecules which are written here as found to be some promise, not available in India yet. If it is hypokalemia, I think we have definite protocols to treat with IV pot flow therapy and others, and that happens more if you are using more of furosemide therapy in these patients. If you see this, this cartoon shows clearly that the risk of developing hyperkalemia is much less with RNA compared to ACE inhibitors or receptor blockers. The other important thing which we said is presence of anemia in these patients of heart failure. If the patient has iron deficiency, then less than 100 nanograms of serum ferritin, straight away they benefit. And if sometimes iron levels are 100 to 299, but still transferrin saturation is less than 20%. These are the subgroup patients which are benefiting by this ferric carboxy maltose IV infusions. I think it is available now. It is now come to therapy. So various studies have shown that it does significantly good to these patients in the class 2A indication. So in the comorbidities associated, if patient has anemia, iron deficiency anemia, especially therapy with IV ferric comorbidity maltase is again indicated. If you try to see what are the other major problems and gaps in this which are happening in these patients of heart failure, generally lack of awareness in general population, and then probably lack of testing facilities of echo testing or natriuretic peptide testing, and probably we need to be not to be relaxed just because patient is asymptomatic. It doesn't mean that they will be stable.